Sir, we cannot hear you, sir.
Can you hear me now?
Yes, sir, yes.
So a warm welcome to all of you, and I thank Dr. Vedvati for introducing me. Dr. Vedvati is a senior physician and the senior most diabetologist at the Chellaram Diabetes Institute. Let me begin by saying a few words quickly about the institution. The Chellaram Diabetes Institute has four pillars. One is patient care, reflected by the Chellaram Hospital, diabetes care and multi-speciality. We also have education and the educational courses. We believe in awareness and we have a rural outreach program. We also have a magazine, Diabetes Health. And of course, we have a research unit which does high quality clinical research. Our aim and vision is to make an impact on the treatment of diabetes in India. And you will be aware that we have some of these courses on our e-learning platform. One on diabetic foot, the other on basics of diabetes management. We have recently started a course on gestational diabetes, and our course on lipid disorder management is already extremely popular. So this is the CME certificate course on the prevention and management of diabetic kidney disease. And this course is going to have 4 faculty. Of course, I'm only the person presenting this module, but a lot of hard work has been done by our team. I'd like to thank Dr. Shailesh, who's the head. Dr. Shailesh Deshpande is a senior specialist in public health and community medicine, and he heads the educational courses at the Chellaram Diabetes Institute, where he is a full-time employee committed to developing high-quality educational content. Dr. Vedvati Purandare is our senior most diabetologist. She has been in the institute for as long as I can remember, right from the beginning of the institution. And she is a very, very committed clinician with publications, research, and vast clinical experience. Then finally, we have Dr. Charan Bale, who is a consultant nephrologist at the Chellaram Diabetes Institute, and also affiliated as a professor in Medical College at Pune, and he will also be taking one of the modules. So this is a structure that we are going to have. I'll talk about initially the first module that's going to be covered by me would be basic considerations of diabetes with emphasis on diabetic kidney disease. Then we would have introduction and to overall management of diabetic kidney disease. The third module would be glucose control and diabetic kidney disease, lessons from large trials. And the fourth one would be oral anti-diabetic drugs and emphasis on glucose control and diabetic kidney disease. The fifth module would be advanced anti-hyperglycemic therapies in diabetic kidney disease. And the final module would be special aspects, including management of glucose control during dialysis, transplantation, the role of ambulatory peritoneal dialysis, the role of other important aspects like management of anemia, management of clinical management of patients who have advanced renal diseases, new onset diabetes after transplantation, etc. So I welcome you to this module, and I'd like to begin by thanking Savia for this collaboration, which helped us to reach out to so many doctors. And one of the goals of Chellaram Diabetes Institute is to make an impact on diabetes care in India via education. And what better way to start today's meeting by remembering all the doctors out there, and how thrilled that we are with you today, and how happy that our treatment is going to help so many people with diabetes across the world. So let me begin with the first module on the CME certificate course on the prevention and management of diabetic kidney disease. And this module will look at diabetes mellitus basic considerations, its emphasis on diabetic kidney disease. I will begin with the epidemiology of diabetes, and we know that to define diabetes is to say that it's a disease in which the body's ability to produce or respond to the hormone insulin is impaired, and this results in an abnormal metabolism of carbohydrates, lipids, and proteins, and ultimately this increases the level of glucose in the blood. Across the world, the total number of people with diabetes is rising. And last check in 2019, there were 463 million people with diabetes worldwide. If you look at the raw data prevalence, and if you just look at this area of the world, which is Southeast Asia, the prevalence of diabetes is about 8.8%. So we've looked quickly at the epidemiology of diabetes, and I'll focus mainly on diabetic kidney disease, but I'll also introduce now the classification and diagnosis of diabetes. We know that diabetes can be of 4 types. Type 1 diabetes, where there is an absolute lack of insulin, needing lifelong insulin, and a predilection for ketoacidosis. Type 2 diabetes, as we all know, has insulin resistance and reduced beta cell function. So 2 problems in type 2 diabetes. Type 2 diabetes, by far the commonest form of diabetes worldwide. The third, we have hyperglycemic milieu of pregnancy, leading to pregnancy-related diabetes, gestational diabetes, which disappears after delivery. And then we have the other specific types of diabetes. For example, pancreatic damage, pancreatitis, chronic pancreatitis, pancreatic surgery, steroid-induced diabetes, maturity onset diabetes of young, etc. These are the specific types of diabetes. But like patients don't read textbooks and like diseases don't read textbooks, there are several forms of diabetes which cannot be classified into, say, type 1 or type 2 or other forms. For example, you have latent onset diabetes of the adult. Latent autoimmune diabetes of the adult is also called LADA, which is a slowly progressive form of type 1 diabetes, mimics type 2 diabetes initially, but people quickly require insulin. So there are several forms of diabetes which may not really fit into tight compartments. We know that there is diabetes, and we know that there is a stage before diabetes, which is called pre-diabetes, and there is a stage before pre-diabetes, and that's called not pre-diabetes, but that's called normoglycemia. So from normoglycemia, patients with diabetes get pre-diabetes, which is impaired fasting glucose or impaired glucose tolerance, and then they get diabetes. In type 2 diabetes, it may not be initially insulin requiring, can be managed with oral drugs, but then they require insulin later on for glucose control. Again, I know this is very basic, but since this is a course, we should cover this in some general terms. Diabetes is defined by a fasting of more than or equal to 126, or a postprandial that's more than, sorry, not postprandial, post 75 grams 2-hour glucose load value of more than or equal to 200, or a random glucose of more than 200 with symptoms, or HbA1c of more than 6.5%. So I've looked at the epidemiology of diabetes. I showed you that the number of people with diabetes in the world is somewhere around 463 million in 2019, and that in Southeast Asia, you have about 8.5 to 9% of the population affected by diabetes. I also looked at the diagnosis of diabetes, where I talked about diabetes being a disease of glucose metabolism, and I looked at the classification of diabetes, and I also defined the criteria for diabetes, discussed pre-diabetes. So that was the introduction, and let me now go on to the complications of diabetes. Now, the complications of diabetes can be divided into vascular and non-vascular. What are the non-vascular complications of diabetes? Diabetic ketoacidosis is one. Hyperosmolar hyperglycemic coma is another. Infections like diabetic foot infections, urogenital infections, or other tuberculosis are all non-vascular complications. But here we are to discuss nephropathy, diabetic kidney disease, and I will now talk about diabetic vascular complications. So you have microvascular complications like neuropathy, nephropathy, and retinopathy, and you have macrovascular complications like coronary artery disease, stroke, and peripheral vascular disease. Now, how does hyperglycemia lead to vascular complications like nephropathy? Hyperglycemia causes oxidative stress. Hyperglycemia via glycosylation and protein kinase C activates the polyol pathway. Hyperglycemia directly binds glycates, certain proteins which are present in the kidney, and the eyes and so on, and they affect the tissues, blood vessels of these tissue organs. And of course, hyperglycemia drives endothelial dysfunction. So oxidative stress, polyol pathway, tissue glycation, endotheliopathy, and a host of other mechanisms lead to vascular complications, including diabetic kidney disease. There's a subtle difference between microvascular and macrovascular complications. Now, if you look at the microvascular complications like neuropathy, nephropathy, and retinopathy, they are the hallmark of diabetes. You cannot see a Kimelstein-Wilson lesion of diabetic kidney disease in a person without diabetes. It's very uncommon. You can see a classic diabetic nephropathy only in diabetes. You can see a proliferated diabetic retinopathy with vitreous hemorrhage and pre-retinal hemorrhages, subhyaloid hemorrhages only in diabetes. You can get the classical pattern of diabetic neuropathy only in diabetes. So if you want, some people believe that if you want to define diabetes, you must define it by the microvascular complications, which are the hallmark of diabetes. So this point I want you to take home is that microvascular complications such as neuropathy, nephropathy, and retinopathy are seen, not just seen only in diabetes, but they are the hallmark of diabetes. Diabetes is defined. We treat diabetes because we want to reduce the microvascular complications. But this doesn't mean that diabetes does not have macrovascular complications. Diabetes is associated with an increased risk of coronary artery disease, increased risk of stroke, increased risk of peripheral arterial disease. But these diseases like coronary artery disease and stroke are also seen in people without diabetes. So that's important to know, because the important thing about preventing the onset and progression of microvascular complications is the control of glucose, because diabetes is defined by that. But to treat macrovascular complications such as neuropathy, nephropathy, and such as coronary artery disease, stroke, and peripheral vascular disease, these are the three macrovascular complications. The way to treat it is not just glucose control. You will have to treat hypertension, obesity, dyslipidemia, etc. But this does not mean that to prevent the microvascular complications, lipid or blood pressure control is not important. It is important, but glucose control takes center stage in the management of microvascular complications. The others take a backstage, but equally important. But for macrovascular complications like coronary artery disease, all are important. Not just glucose control, but lipid control, hypertension, weight reduction, etc. With that, we go on to the main introductory aspects of diabetic kidney disease. Now, what is diabetic kidney disease? Diabetic kidney disease is a clinical diagnosis in patients who have very long-standing diabetes. Patients with very long-standing diabetes, more than 10 years usually, with albuminuria and or reduced glomerular filtration rate in the absence of signs and symptoms of other primary kidney diseases. So you will see that it is in some ways a diagnosis of exclusion that you need to have. First of all, it's a clinical diagnosis. Usually it is long-standing diabetes. Usually it is defined by albuminuria and reduced eGFR, but it's also defined by the absence of other primary kidney diseases. I'd now look at the epidemiology of diabetic kidney disease. Diabetic nephropathy is also the other term for diabetic kidney disease. Diabetic kidney disease, retinopathy, and neuropathy, as I mentioned, are the microvascular complications of diabetes. Diabetic kidney disease contributes to the mortality as well as the morbidity in diabetes. Now, this is a study published from Hong Kong, which is one of the most important renal registries. This is Hong Kong registry, and what is very, very apparent in this is that the red line in the graph out there, the x-axis shows you the years and the y-axis shows you the incident counts. What is immediately apparent is that as a cause of renal replacement therapy, as a cause for a patient requiring dialysis or transplantation, the red line is above all the other lines. So diabetes stands out as being higher as a cause of renal replacement therapy when compared to glomerulonephritis, uh, other urological causes, cystic kidney disease, and other hereditary disorders. And it's important to note that diabetic diabetes as a cause of renal replacement therapy increased from 26.2% in 1996 to about 49.6% in 2013, which means that nearly half of patients, or rather, if you look at the real life situation, is probably even more than that. Nearly 50% of people on dialysis or uh, requiring transplantation have diabetic kidney disease. This shows you the importance, and we deliberately showed you this Asian data because we in India are an Asian country. This looks at the stages of the chronic disease, chronic kidney disease, and albuminuria. This is the KDIGO guidelines, which suggest that we must look at classifying or staging kidney disease based on two criteria. One is the GFR criteria, and the other is the albuminuria. Look at the GFR criteria. You can have GFR of uh, 5 categories: G1, G2, G3, G4, G5. G1 is when the eGFR is above 90. G2 is when there is kidney damage and there is a mild reduction in eGFR to 60 to 89. In G1, which is an early disease, you may even have an elevated eGFR. But when you look at G2, there is kidney disease and reduction in the glomerular filtration rate to 60 to 89 ml per minute or 1.73 meters squared. In grade 3 or G3, you have a moderate reduction in GFR. It becomes 30 to 60 or 30 to 59. And in G4, you have a severe reduction in GFR, 15 to 29. And when we reach G5, it's called kidney failure. Some people call it end-stage renal disease or end-stage kidney disease. And here, you will see that the GFR is below 15 ml per minute per meter square, or the patient may require dialysis. So chronic kidney disease, how do you define chronic kidney disease? Whether it is due to DKD or some other cause. Chronic kidney disease is defined as GFR below 60 ml per minute for more than 3 months, and kidney damage is defined as pathological markers of damage, including albuminuria or other abnormalities. So these are the stages of albuminuria. So earlier, we used to classify albuminuria as microalbuminuria and macroalbuminuria. Now that classification has completely gone away. Now, you are defining albuminuria by A1, A2, and A3. It is assessed by a spot urine albumin creatinine ratio. I will talk about that in the next few slides. But A1 is normal or mild increase in albuminuria, and it's defined as a urine albumin to creatinine ratio of below 30 milligrams per gram. Then you have moderately increased albuminuria. The old term for this was microalbuminuria. Today it is not micro but moderate. Moderately increased albuminuria of 30 to 300 milligrams per gram. And A3 is severely increased albuminuria. That is the old term for this was macroalbuminuria, but today we call it severely. So micro has become moderate and macro has become severe, and this is defined by a urine albumin creatinine ratio of more than 300 mg per gram. Now, this was a study which looked at how common is diabetic kidney disease. This is called the demand study. This is a developing education on microalbuminuria awareness of renal and cardiovascular risk in diabetes. Large global study which looked at 32,208 subjects with type 2 diabetes. They looked at eGFR, estimated GFR, and albuminuria, and they found that eGFR or estimated glomerular filtration rate was below 60 in 22% of people with diabetes, and the prevalence of uh, normal, micro, and macro was 51, 39, and 10. So if you club together micro and macro albuminuria, you will find that 39 plus 10, almost 49% of people with diabetes at any stage have some form of diabetic kidney disease, underscoring its importance. Now, albuminuria is also related to chronic kidney disease. what you will find is that in the stage 1, I discussed the stage 1, G1 stage according to GFR, you will find that the majority of patients had normal albuminuric, some had microalbuminuria, and some had macroalbuminuria. But you will find that as you go from stage 2 to 3 to 4 to 5, the proportion with normal albuminuria comes down, and the proportion of subjects with microalbuminuria goes up, and macroalbuminuria also goes up. Look at stage 5, only 29% have normal albuminuria, 47% have microalbuminuria, another 24% have macroalbuminuria. So if you look at stage 5, you will find that albuminuria is present in almost 47 plus 24, that's about 71%. Let's look at the case now. A 45-year-old lady comes with type 2 diabetes for 12 years. She's visiting your hospital for the first time, and she's taking premix insulin, 20 units in the morning and 20 units in the evening. Her blood pressure is 180/100 on amlodipine. She presents with a poor appetite, nausea, and occasional vomiting. She has, last 6 months, she has numbness of both feet and below the knees, numbness. Obviously, she has diabetic neuropathy, and she has not checked the blood glucose levels. Well, this looks like a rare situation, but it is pretty common, because even today I had a patient who's from a very remote part of the country who has actually present with a similar situation. The only thing is that she has completely stopped her insulin on her own. So this sort of patient is quite common in clinical scenario. And we look at her values. What you will see that is that her HbA1c is 11.8%. Obviously, she requires better glucose control. She has got diabetic kidney disease because the eGFR is 23 ml per minute. She's got albuminuria. In fact, she has severely increased albuminuria. If you look at the criteria, her urine routine is normal. So she's got 24-hour albumin in the kidney if production. And normally you would like to see urine albumin of 1+ or so, but her urine routine is normal. Obviously, it needs to be repeated. Her ultrasound abdomen shows altered renal parenchyma, and just to show the kidney size may be normal in diabetic kidney disease. Her eye examination shows severe non-proliferative diabetic retinopathy, and therefore, and the ECG is normal. And the presence of retinopathy suggests that this lady's kidney disease is likely to be diabetic kidney disease. So these are the 3 clinical questions here. I'm not going to discuss management because we have 6 modules and this is the first module. But I just broadly cover what should be the plan of her glucose control and what are the comorbidities that she has. So, ladies and gentlemen, clinically the diagnosis is likely to be diabetic kidney disease because she has coexisting retinopathy. She has stage 4 CKD. She has albuminuria. The eGFR is 23. That means it is stage 4 CKD. What should be the plan for management? Control of hyperglycemia. I'd like to put her on a basal bolus insulin regimen. I'd like to control her blood pressure, lipids, management of vomiting, and further evaluation. And what are the comorbidities does she have? She's got retinopathy because she's already got proliferative retinopathy, and she's got symptoms suggesting a severe diabetic neuropathy, and she will require cardiac evaluation also. So I've looked at the prevalence of diabetic kidney disease in type 2 diabetes, showing you that if you look at a low eGFR, about 22% have a low eGFR. But let's look at diabetic kidney disease in type 1 diabetes. Look at type 1 diabetes, about 10 to 35% of people with type 1 diabetes will develop end-stage kidney disease. 25% of type 1 diabetes will develop macroalbuminuria, and 40% with type 1 diabetes will develop microalbuminuria. Let's look at another case, a 40-year-old gentleman. Note, this gentleman has type 1 diabetes for 25 years. The blood pressure is high, 160/96. The HbA1c is high, 13%. He's on 2 injections of NPH, which is a basal insulin, and 3 injections of regular insulin. The fasting is high at 277. The postprandial is high at 444. The blood urea is slightly high at 44. Serum creatinine is 1.6. Urine albumin creatinine ratio shows moderate albuminuria. The old term for this would have been microalbuminuria, and the eGFR is 45 ml per minute. And therefore, this patient What is this? I'm going to ask you. So you know that this patient has diabetic kidney disease, but I want to answer three scientific questions here, not clinical questions. What is the association with type 1 diabetes and nephropathy? Because this patient has nephropathy or DKD. In terms of diagnosis and prognosis, how is diabetic kidney disease in type 1 diabetes different? And what would be the management strategy? So the answers to that are, ladies and gentlemen, as discussed before, 40% of subjects with type 1 diabetes would have diabetic kidney disease. As compared to type 2 diabetes, obesity and dyslipidemia are not very common in type 1 diabetes. So the focus of managing DKD in type 1 diabetes should focus on hyperglycemia management and hypertension management. What would be the management strategy? Again, I'm not going to discuss management, which will be covered by my esteemed colleagues in the next few modules. But one of the important management strategies would be basal bolus insulin. Maybe you would consider insulin pump therapy, and of course, ACE inhibitors or ARBs. There are several risk factors for diabetic kidney disease. Some you can change, some you can't change. We can't change our parents. So genetics is not a changeable risk factor. We can't change the place where we are born. So ethnicity, South Asians are at higher risk. Age is also something we can't change as we grow older. But when people are very old, people with diabetes who are extremely older, with diabetic kidney disease, they don't survive. So if you see falsely, there's a paradox. The prevalence may falsely come down, but actually it shows more deaths. So age increases the risk of diabetic kidney disease. Diabetes duration is also a very important factor. Presence of other diabetic complications like autonomic neuropathy, cardiovascular disease are factors. Inflammation, cytokines, and growth factors all drive diabetic kidney disease. Presence of dyslipidemia or the metabolic syndrome has been shown to be an important factor in the onset and progression of diabetic kidney disease. Hypertension and blood glucose are again, hyperglycemia are also most important factors. I've looked at the epidemiology of diabetic kidney disease. I've looked at the epidemiology of diabetes also. We looked at the classification and diagnosis of diabetes, complications of diabetes. We've defined diabetic kidney disease. Now, in the last part of my presentation, I'd like to suggest how to screen for diabetic kidney disease. Now, I showed you a very simplified definition of diabetic kidney disease. But here is a more thorough definition of diabetic kidney disease. Diabetic kidney disease is defined by albuminuria, increased urine albumin creatinine ratio of more than 30 milligrams per gram, and or a progressive reduction in GFR, glomerular filtration rate. It usually occurs in the setting of a long duration of diabetes. But microalbuminuria can be present in about 10% of people with type 2 diabetes, even at diagnosis. Typically, diabetic kidney disease is associated with retinopathy. Other causes of kidney disease should be ruled out by appropriate assessments, and kidney biopsy will be discussed later. It's rarely necessary, but it's conclusive if you have a doubt. Now let's look at the screening of diabetic kidney disease by albuminuria. So people with diabetic kidney disease can have albuminuria, but a small proportion may not have albuminuria. That's called non-classical, non-albuminuric DKD. But the presence of albumin in the urine is a hallmark of diabetic kidney disease. You can check for albumin in urine by three methods. One is the spot albumin creatinine ratio. This is recommended by the American Diabetes Association. Normal is less than 30 milligrams per gram. It does not require fasting, but it's better to do it early in the morning because standing and physical activity can increase the albumin excretion a little. So it's better done in the morning. So spot morning urine albumin creatinine ratio is best because it's very convenient to do it in a routine clinic. Timed urine collection is probably a most accurate way, but in clinical practice, it's prone to error. A 24-hour urine albumin creatinine ratio is the third way, but it is quite cumbersome. All the abnormal tests should be confirmed in 2 out of 3 samples. And once your patient has albuminuria confirmed in 2 out of 3 samples, you must test it more frequently. Screening should not be performed in the presence of urinary infection, hematuria, acute febrile illness, exercise, short-term hyperglycemia, hypertension, and heart failure. This, I'm rushing through this part where you can get false positive microalbuminuria because it will be discussed in detail in the next module. And again, as I mentioned, once you have a positive urinary album creatinine ratio, check the EGFR every 3 to 6 months. Many patients have the doubt, why are we checking urine albumin creatinine ratio, doctor? Why not just check urine albumin? Because microalbuminuria is small amounts of albumin in the urine. The answer is correcting the albumin for creatinine will correct for the degree of fluid intake or lack of fluid intake in the body. For example, a patient who takes a lot of fluid may have a falsely low urine albumin, but the urine albumin creatinine ratio will be constant. A patient who does not take much water, dehydrated, may have a concentrated urine with a high urine albumin, but the urine albumin creatinine ratio will be normal. That's one of the reasons why we check the urine albumin creatinine ratio. Now, let's look at the second method, which is the EGFR. The EGFR is a formula, and in the next module, you will be shown several apps and how to calculate it, etc., etc. But it is a formula which can be calculated by using the age, the gender, serum creatinine, and the body size. There are three formulas which are very commonly used. Let me begin from the first. That is the MDRD formula, which is the modified diet and renal disease. This is very good formula to use, but it is not very accurate in when there is a EGFR that is more than, when there's a GFR more than 60. Especially in type 2 diabetes or type 1 diabetes, in the early stage, there may be hyperfiltration and increased EGFR, and MDRD is not very accurate between 60 to 90 or even higher. The Cockcroft-Gault formula is always, I remember it because I remember reading about it during my MBBS days, which was, I think in 1987, I joined for MBBS several years ago. But the Cockcroft-Gault formula is not useful because it was based on people who had normal kidney function data. So it's not based on abnormal kidney function data. So therefore, the CKD-EPI equation, or the chronic kidney disease epidemiology collaboration equation, which is reasonably accurate if you take all levels of EGFR, even between 60 to 90, and even at the hyperfiltration levels, it is a very accurate form of assessment. So that's one. So that's the one recommended by the American Diabetes Association. So always use the CKD-EPI. The other reason why CKD-EPI is preferred is because it has been correlated very well. A falling EGFR by the CKD-EPI formula has correlated very well with renal disease mortality and end-stage renal disease requiring renal replacement or transplantation. So that's the reason why the CKD-EPI formula is better. And remember, whenever I look at these formula, I ask myself, how did they take EGFR of below 60 as normal? On what basis? So if you remember osteoporosis is defined by a T-score of minus 2.5, which means a bone density which is below 2 SD of normal. So an EGFR of 60 is also a very similar concept. An EGFR of 60 has been taken because we look at large population studies of EGFR. A value of 60 is about 2 standard deviations below normal, and that's why it has been taken as 60 to say somebody has CKD. This slide shows you a natural history of diabetic kidney disease, which is very important to understand if you want to understand diabetic complications. You can see here the GFR in the purple color and the onset of nephropathy, the EGFR in the purple color and the nephropathy here. So the green color is albuminuria and the purple color is EGFR. You can see that as the EGFR drops, the albuminuria increases. So to set you up for the next module that's coming in, I want to make one clinical point is that the presence of albuminuria hastens the worsening of kidney disease, rising creatinine, and a falling EGFR. Second thing I want to show you is that in very early kidney disease, there is a hyperfiltration, probably nephromegaly, and some amount of microalbuminuria at this stage that may occur. So in early kidney disease, there may be hyperglycemia. Now, some patients will see that once glucose control is achieved, the hyperfiltration comes down. And some people, it may not come down, but hyperfiltration is the hallmark. And the second, so therefore, as the proteinuria increases, EGFR decreases. Second part I want you to focus on is a natural history in some detailed ways. You can see in red color the blood pressure rising. You can see the albuminuria increasing. You can see the albuminuria increasing in the green color, and you can see the GFR falling in the black color. Now, very interestingly, uh, if you see, albuminuria actually predates the fall in EGFR, but there is a time point at which all three seem to cluster. The blood pressure has started going up, the albuminuria has started increasing, the EGFR has started falling. So that is a cusp at which your patient stands on the verge of falling into the precipice of diabetic kidney disease. And that point it's very important to diagnose. So it's important to pick up that point in clinical practice and watch out. Is this patient's EGFR going down? Is the albuminuria picking up? Is the BP picking up? And that gives you a signal that things are on the cusp of going away, going worse. So I think this is something to understand here. So when I talk about this natural history, this is the natural history of diabetic kidney disease, classic diabetic kidney disease. But there is also another form of diabetic kidney disease, which is also called non-classic diabetic kidney disease. Some people refer to it as non-albuminuric diabetic kidney disease. How did this come about to be? Philosophically, many doctors believe, many scientists believe that albuminuria is not the hallmark of GFR. In some studies, it has been shown that even before albuminuria, there is a 1 to 2% fall in EGFR. So that's why they found a lot of, and in clinical practice, you see a lot of patients with falling EGFR, but you see that albumin isn't high. If you look at this picture, the green color, you can see that the albumin may come up, come down, go up, go down, but the GFR consistently falls. Now contrast that with the earlier picture where there is increasing albuminuria and falling EGFR. This is classic diabetic kidney disease. And this is non-classic diabetic kidney disease. Blood pressure is high, the GFR is falling, but there is no albuminuria. This is also called non-albuminuric diabetic kidney disease. Why does this happen? Some people believe that albuminuria is not yet started, it's going to start later. This can also occur in clinical practice if your patient is on ACE inhibitors or ARBs, which can suppress proteinuria. But nowadays, scientists have researched this, and found that these people may have a different pathology. Indeed, the pathology of these patients may be that they have a form of arteriosclerosis. Now, if you look at the classic diabetic kidney disease, as I showed you in the previous picture, the classic diabetic kidney disease has a biopsy showing mesangial basin membrane thickening, mesangial expansion, so on and so forth, tubular sclerosis. But here, in diabetic kidney disease of the non-albuminuric variety, people suggested that atherosclerosis or arteriosclerosis also could be a pathology. So this seems to be a vascular phenomenon. And albuminuria is not seen in this group. But it's important to note that almost 24% of type 1 diabetes subjects with kidney disease would have a non-albuminuric form of kidney disease, whereas 76% of type 1 diabetes with diabetic kidney disease would have a classic diabetic kidney disease. If you look at type 2 diabetes and look at all the DKDs in type 2 diabetes, what you will find is that 20% of type 2 diabetes could have 20% of the type 2 diabetes related diabetic kidney disease could be of the non-albuminuric variety. So it's important to recognize and research non-albuminuric DKD because that's emerging as a very important. And in the slides to come, not just this will be discussed, we'll also discuss non-diabetic kidney disease. Friends, it's important to note that albuminuria does not just indicate kidney disease. Albuminuria increases the risk of mortality. If you look at normal albuminuria versus microalbuminuria. Microalbuminuria subjects have almost a twofold increase in mortality. If you look at normal albuminuria versus persistent macroalbuminuria, of course, the new terms for macroalbuminuria is severely increased albuminuria or persistent proteinuria. The risk of mortality is almost 3 to 4-fold, and this is true for CV death and total death. And if you look at end-stage renal failure, you will see that if you look at the total death, you'll see that the mortality of is as high as almost 6 to 7-fold. And this is true not just for type 1 diabetes. In the previous slide, I showed type 1 diabetes, but this is true for type 2 diabetes as well. You can see that when you go from no kidney disease to albuminuria to impaired GFR to albuminuria and impaired GFR, there is a steady increase in the risk of mortality even in type 2 diabetes. And if you look at the albuminuria plus eGFR group and compare it to the no kidney disease group, there is almost a 10-fold increase in mortality. And just to again highlight that point, that albuminuria and eGFR together increase the risk of cardiovascular events. So many people with albuminuria and reduced eGFR may not necessarily have a renal cause of death. They may die of cardiovascular events. They may have cardiovascular events. They may have cardiovascular death, and they may also have renal events. So I think it's important to note this point that albuminuria plus a reduced eGFR is important to consider. Diabetic kidney disease should be prevented and treated because these are my summary slides. The presence of diabetic kidney disease increases cardiovascular and renal mortality. Diabetic kidney disease is associated with all-cause mortality. Worsening diabetic kidney disease may require renal replacement therapies such as dialysis or transplantation, which means that better prevented rather than having to treat it. Better for the patient to prevent it. And similarly, DKD, end-stage kidney disease, etc., are associated with anemia, gastrointestinal disorders, metabolic bone disease, dyselectrolytemias, acute kidney injury, pulmonary edema. So these are all components of diabetic kidney disease because diabetic kidney disease worsens the quality of life. Not just it's a cause of mortality, it worsens the quality of life and it can become a systemic disease. Therefore, we must prevent the onset and progression of diabetic kidney disease. My presentation, I've looked at the basic aspects of diabetes, the epidemiology of diabetes, the epidemiology of diabetic kidney disease. I've shown you a glimpse of the natural history of diabetic kidney disease, and I've shown you how to screen